Hi, today we're going to cover COVID-19, what we should know. The objectives of this presentation is to go over the ICD-10-CM coding guidelines, common examples, and telehealth. So with the pandemic going on right now, there are a few changes that actually came about as of April 1st, 2020. So let's go and find out. Coronavirus. The virus names SARS-CoV-2. The actual disease name is COVID-19. On December 31st, 2019, it was first detected in Wuhan City, China. The transmission was from person to person contact by way of sneezing and coughs. So, in the biology world or the medical world, zoonotic. It came from bats to humans. So, the symptoms of COVID, for the most part, the most common ones were and are fever, cough, and shortness of breath. The symptoms may appear 2 days or as long as 14 days after exposure. So that's why we're quarantining if you have it for at least 14 days. The first 7 days are the contagious days, and then thereafter, you have to still recover. The high risk patients are 65 years old and older, and people in nursing homes, long term care facilities. Also, with people with asthma, heart conditions, any immunocompromised systems, cancer, high BMI, and pregnant women. So we're going to get into the guidelines. Of course, the guidelines, they became available for April 1st, 2020. I'm going to go over some points of the guideline, but not all of them. So I just want everybody to kind of be aware of them. You can, at the end of this presentation, I have the references. So if you don't have a copy of the new guidelines, there's a link where you'll be able to go and get the copy if need be. So ICD-10-CM for reporting. So prior to April 1st, 2020, ICD-10-CM code B9729, other coronavirus as the cause of diseases classified elsewhere. Well, the CDC implemented a new ICD-10-CM code for reporting coronavirus 2019, effective April 1st, 2020. So now the code is U07.1, COVID-19. This should be sequenced first when it meets the definition of principal or first listed diagnosis, and followed by the appropriate codes for any associated manifestations, except newborns and obstetrics. So, Chapter 1, Coding Guidelines. So this is the part that was actually added and has taken place in our guidelines as of April 1st, 2020. Coronavirus infections, of course, we stated that the infection is due to SARS, so it's a SARS infection. You code only confirmed cases as documented by the provider. Of course, everything is built on documentation. Documentation of a positive COVID-19 test result or presumptive positive COVID-19 test result. So for confirmed cases, assign code U07.1. This is an exception to the hospital inpatient guidelines, section 2H. In this context, confirmation does not require documentation of the type of test performed. The provider's documentation that the individual has COVID-19 is sufficient. So, documentation. You want it from your provider. Presumptive positive COVID-19 test results should be coded as confirmed. Um, for the most part, when all of the outbreak occurred, they wanted basically once someone was presumed positive, to send the actual results off to the Centers for Disease Control and Prevention, which is the CDC, so that they can get a true confirmation. Well, as of now, this is no longer in place. All of the actual test results, rather if it's documented as positive or presumed positive, it is positive. Okay. And of course, we have our good old, if the provider documents suspected, possible, probable, or inconclusive, do not assign code U07.1. So this kind of follows in our regular guidelines, and this is definitely for outpatient. Assign a code explaining the reason for the encounter. So if the person came in for fever or shortness of breath, then we would document and code fever and shortness of breath. Or if they had contact with someone or expected exposure to someone who may have had COVID, we would use the Z20.828. Also here, this will be the sequencing. For the most part, in the sequencing, as long as it's meeting the criteria for principal for diagnosis, I should say, we are going to code the U07.1. The only time this does not take effect is in the pregnancy area. So O for obstetric, and for this reason here, we will use our O code for this here. So basically, when COVID-19 meets the definition of principal diagnosis, code U07.1 should be sequenced first, followed by the appropriate codes for associated manifestations, except in the case of obstetrics patients as indicated in section 1C15S for COVID-19 in pregnancy, childbirth, and the puerperium. For COVID-19 infection that progresses to sepsis, we see section 1C1D, sepsis, severe sepsis, and septic shock. So we have all of the guidelines, the updated guidelines that's showing in these different areas. So we will follow the guidelines as such to make sure that we are coding correctly as far as the sequencing. Now, for acute respiratory illnesses due to this here, for the most part, you're going to see pneumonia, bronchitis, lower respiratory infections, acute respiratory distress syndrome. We've seen a lot so far in coding this year. And for the most part, a lot of patients have some of the same symptoms, the common mild symptoms, I should say. And then you have some who progress to a little bit into a different diagnosis like the pneumonia and the bronchitis. So for pretty much all of these here, basically you're going to code the COVID first, and then you're going to use whatever their associated manifestations is thereafter. And as long as it says due to, so the physician has to definitely tell you whatever their associated manifestations that they have is definitely due to the COVID-19. Okay. Um, let's move on. Like I said, I'm not going to read everything because for the most part, as coders, we all have the guidelines at this particular point. And if you don't, like I said, at the end of the presentation, just be sure there's a link. You can actually click on it or either hit control and then click on it, and then you'll be able to print it out. And if that doesn't work, just copy and paste into a new browser, and you should be able to print it out then. Exposure to COVID-19. This is for cases where there is a concern about a possible exposure to COVID-19, but this is ruled out after evaluation. So the code for that would be Z03.818. And counter for observation for suspected exposure to other biological agents ruled out. For cases where there is an actual exposure to someone who is confirmed or suspected but not ruled out to have COVID-19, and the exposed individual either tests negative or the test results are unknown, then you would assign the code Z20.828, which is the contact with and suspected exposure to other viral communicable diseases. If the exposed individual tests positive for the COVID-19 virus, see guideline A. Now we have our screening. So the screening for asymptomatic is no symptoms. For asymptomatic individuals who are being screened for COVID-19 and have no known exposure to the virus, and the test results are either unknown or negative, then you use the code Z11.59, which is the encounter for screening for other viral diseases. Now, for individuals who are being screened due to a possible or actual exposure to COVID-19, see guideline D. If an asymptomatic individual is screened for COVID-19 and tests positive, see guideline G. So for the most part, we've kind of already gone over, if they are positive or presumed positive, they are confirmed, and then you have some other guidelines that has surrounded the asymptomatic or exposure to someone who has it or encounter for observation. It's kind of pretty much just like the rest of the areas in the guidelines when you see these codes, basically. So we're just kind of following suit. Which is something we already know. As coders, we already know our guidelines. So for us to follow suit, we're actually following the same suit we've been following at this particular point. We're just making sure because this new disease is coded correctly. Now, signs and symptoms. Of course, the basic guideline, if there is no definitive diagnosis, then you code the sign or symptom. This does not change in this manner. So for patients presenting with signs and symptoms associated with COVID, but a definitive diagnosis has not been established, assign the appropriate code for each of the presenting signs and symptoms such as. So if the patient is coming in for cough, shortness of breath, and fever, and we don't have a definitive diagnosis if this is definitely COVID or not, or if it's anything else, then we are still going to code the signs or symptoms. Now, if a patient with signs and symptoms associated with COVID-19 also has an actual or suspected contact with or exposure to someone who has COVID-19, once again, the Z20.828 contact with and suspected exposure to other viral communicable diseases as an additional code. Additional, okay? And you will find this in guideline section IC21C1, contact and exposure. So here's an example of that one here, because for the most part, we would actually use that code as the primary if it's contact with and suspected. However, because this patient has signs and symptoms, then it's coded a little bit different. So that's why it says right here as an additional code. So a few days after caring for an ICU patient with coronavirus, a nurse began having shortness of breath and a fever. She has a history of mild intermittent asthma for which she uses an inhaler, and she receives a nasal swab test for the coronavirus, which is pending. So pending, knowing that it's pending at this particular point, we don't have a definitive diagnosis. We're going to code the signs or symptoms, which is her shortness of breath and the fever. The fact that she has asthma, because that's still part of the respiratory system, the asthma, we're going to code. And then because she took care of an ICU patient with coronavirus, this will be contact with and suspected exposure to other viral communicable diseases. Okay, so that's how we would actually code that. Asymptomatic individuals who test positive for COVID, we are basically assigning the U07.1. Now, the individual could definitely be asymptomatic and they can test positive and considered to have the infection. However, now that you know, and even though they don't have any symptoms, if they have to come back to the hospital for this here, you have your definitive diagnosis. Okay, this is if they come back because they're starting to have symptoms and they're getting worse. Okay, so chapter 15, pregnancy, childbirth, and the puerperium. Codes from chapter 15 always take precedence or sequencing priority. COVID-19 infection in pregnancy, childbirth, and the puerperium. During pregnancy, childbirth, or the puerperium, the patient is admitted with a presenting for a healthcare encounter because of COVID-19. The primary diagnosis in this particular case would be the O98.5. Other viral diseases complicating pregnancy, childbirth, and the puerperium. So for the most part, like I said, O for obstetrics, they take sequencing priority over every code in your ICD-10 book. So that would be our code, the O98.5, followed by U07.1. Now, of course, when there are some clinical indicators that are present, like fever, cough, shortness of breath, and only a suspected case is documented at this particular point. Here's the thing, this is what we want to know because um, there's going to be some instances where we're going to have to query the physician, and we want to be as specific as possible. And when a positive, this is a couple of them, when a positive lab test is present, but there is not a confirmation from the provider, remember, it's solely on key. We would have to definitely query the physician. When associated respiratory conditions are not specifically linked to a confirmed COVID-19 infection. So if we see that this patient have some respiratory conditions and they also have COVID-19, we need to be sure that it is either linked to the COVID-19 or not. So in this manner here, because it's such a respiratory disease, we would definitely query the physician on that. Also, another one would be when the documentation is inconsistent between physicians. Um, Sometimes, in emergency rooms, you might have one doctor come in and then he go out, then another one may come on. Just to be clear on what is documented and what is the latest information or prognosis for this patient or whatever. Once you get it and you're still not sure, please query the physician. And then also if present on admission status, if the infection is unclear. So you definitely want to query the physician on that. So these are just some things there to query for the physician. But for the most part, when it's documented, it's confirmed, you can definitely code it. Now, here are some examples, and you'll see this here in your guidelines as well with bronchitis. So, acute bronchitis or bronchitis not otherwise specified, if it is confirmed and it is due to COVID, for the most part, the primary code would be the COVID code, and then whichever of the bronchitis it's going to follow. Here's an example. A former smoker is admitted with a productive cough, dizziness, and chest discomfort. Chest x-ray and PFTs, pulmonary function tests, indicate acute bronchitis. The patient also tests positive for coronavirus. Treatment includes cough suppressants and anti-inflammatory medication, along with isolation precautions. The provider documents that this is likely acute bronchitis due to COVID-19. And of course, the sequencing would be the COVID-19, the acute bronchitis due to other specified organisms, and the fact that the person was a former smoker, personal history of nicotine dependence. So your pneumonia example, same thing, you follow suit. For cases that are confirmed, pneumonia that's confirmed that's due to the coronavirus, of course, once again, the COVID would be first, followed by other viral pneumonia. An example of this would be patient presents with shortness of breath and fever of 103.1. Pneumonia is noted on her chest x-ray, and protocol testing showed that she is positive for COVID-19. Her respiratory status worsens to acute respiratory failure with hypercapnia and prompting oral intubation and mechanical ventilation, which she has now been on for 2 days. The provider documents that the pneumonia is due to COVID-19. So once again, the COVID code is first, followed by the pneumonia for other viral pneumonia, J12.89, and then the acute respiratory failure with hypercapnia. And then this is just some other conditions. As I stated before, because this is a respiratory disease, you have lower respiratory infections, then you have respiratory infections, then we have ARDS, acute respiratory distress syndrome. So for the most part, when it meets the definition of principal diagnosis, then the COVID is actually first and followed by whatever the respiratory infection is for that particular patient. Okay, so now we're going to get into telehealth. I know there had been some questions regarding the telehealth, what to use when they're, on the phone, or if it's a video chat, what's the point of service code we use and all that kind of stuff there. So we're going to get into that. And these have been not only come out from the CDC, and as I stated before, the reference links that I have will be at the end of the presentation. But this is what they are putting out so that we know exactly how to code them. So telehealth, let's first just realize what telehealth is, or just know. This is the exchange of medical information from one site to another through electronic communication to improve a patient's health. So effective immediately, the Office of Civil Rights will not impose penalties for non-compliance with HIPAA rules regarding telehealth. So at this particular point, providers can use the following applications for video chats. We have Apple FaceTime, Facebook Messenger video chat, Google G Suite Hangouts videos, and we have Skype for Business. Just to name a couple other ones, they have Zoom for healthcare. They have Doxy.me, WebEx meetings, Amazon Chime, and GoToMeetings. So there are several avenues to do a video chat. However, you should never, and I don't think I would want to do this either, but Facebook Live, really? Twitch and TikTok. I mean, just let everybody know your business, right? So let's move on. So as of March 7th, 2020, CMS expanded the telehealth benefit on a temporary and emergency basis under the 1135 Waiver Authority and Coronavirus Preparedness and Response Supplemental Appropriations Act. Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, including the patient's place of residence that actually started on March 6th. Doctors, nurse practitioners, Clinical psychologists and licensed clinical social workers will be able to offer telehealth to their patients. OIG, Office of Inspector General. They're providing flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by the federal healthcare programs. And then, of course, that's the waiver, 1135 waiver. HHS will not conduct audits to ensure that an established relationship exists during the public health emergency. Okay, so like I said before, there's going to be some links at the end of the presentation that you can go and pull this information, and you'll be able to read it all in its entirety yourself. So let's just get into the type of visits. So you have your Medicare telehealth, which is telecommunication technology for office, hospital visits, and other services that generally occur in person. Then you have the provider must use an interactive audio and video telecommunication system that is real time, not recorded, not yesterday, not put my makeup on so I can make sure I look cute. None of that. Real time. Virtual check-in. We have codes G2012 or G2010. For your virtual check-in, brief established patient-initiated communications with the healthcare practitioner. So telephone, video, text, email, or a patient portal. So communication is not related to a medical visit within the previous 7 days and does not lead to a medical visit within the next 24 hours. These are typically 5 to 10 minutes, typically. Some cases, of course, are longer. Then you have your e-visits, all types of locations, including the patient's home. Established Medicare patients may have a non-face-to-face patient-initiated communications with their healthcare providers, and these services can only be reported when the practice has an established relationship with the patient. So for the most part, established patient. Now that's kind of get into some of your CPT codes for telehealth. So your G2012 is your virtual check-in. This can be done via telephone call. G2010, remote evaluation of recorded video and or images submitted by an established patient, such as email. Of course, we work in the medical world, and a lot of our the emails that have to go out to people that aren't affiliated with the actual facility, most of the emails are encrypted. At this particular point, because of the pandemic, and it's going from email, they are allowing this here, really without the encryption. G2061 to G2063. Online assessment can be furnished using an online patient portal. Now, this will be used for your e-visits. Your telephone services initiated for established patients. All these are time increment codes. So basically, however long the conversation was via telephone, the code range will be 99441 to 99443, as well as the online digital services initiated for established patients. And notice these are established patients. Of course, these are time incremented as well. Code range 99421 to 99423. Now here's an example. An established patient video conference with their provider. The patient described seasonal allergies, sneezing, runny nose, itchy eyes. The provider did an evaluation via video. This lasted a total of 7 minutes. So the e-visit would fall under 99421 for 5 to 10 minutes of medical discussion with an established patient via online digital communication. Now, this is for the online digital E&M for the office. So this is you talking to your physician, your primary care physician. And of course, we have our physicians or other qualified health professionals that's going to assess you. Of course, for the most part, in most offices, in some offices, you have your RNs, your licensed practical nurses, and your medical assistants performing the throat swabs. If not, then they'll send you over to some kind of testing center. But for the most part, they are doing it in the office. The CPT codes for new established patient would be the 99421 to 99423 area. Also, if you use images and for the virtual check-in, of course, don't forget the G2010 and the G2012. And of course, payer guidelines vary. So you definitely have to check with your payer on this particular, on those two particular codes. Of course, when you've actually tested, getting tested for the actual COVID and it's sent to the lab, it is used with code 87635. And then for the place of service, your place of service, you have 11 for physician office, 19 for off campus, 22 for on campus, and then 81 for independent laboratory. So once again, this here was for the office if you were to see your primary care physician. Now, this here will be if you're going to a testing site. So of course, they have set up several testing sites across the United States, and you know where they are in your particular city and state. So once again, the physicians, qualified healthcare professionals, they're assessing the patients. The CPT codes, once again, for this is code range 99421 to 99423. Don't forget, if you need to use the G2010 and the G2012, make sure that it is covered by that insurance company. The testing sites use the code 99001 for handling and or conveyance of specimen for transfer from the patient in other than an office to a lab. Distance may be indicated. So in other words, at these testing sites, they are handling this particular specimen. Of course, when it is sent to the laboratory, it is going to be, you're going to use the code 87635 for the test of this here. And then the place of service codes, depending on where you are. So they have a couple, 11 for physician office, 15 for mobile unit, 17 for walk-in retail health clinic. You have 19 for off-campus, 22 for urgent care, 20, I'm sorry, for urgent care, 22 for on-campus, 23 for emergency room, and 81 for independent laboratory. Now, this would be unaffiliated with your primary care physician because these are testing sites. So this doesn't have anything to do with your primary care physician. So you just, at some point, a lot of people were just going to the testing sites and just getting tested without even having to go through their primary care physician. So this is for your testing sites. Now this is online digital E&M. Okay, these are your online visits. And just depending on what visit it is or whatever, you'll basically know where to code from. So of course, once again, physician or qualified healthcare professional assessing the patient. Of course, we have our virtual check-in, and if they have to send over images like pictures through email, they could. Your online visits, you have an EHR portal, secure email, and of course, allow digital communication. So of course, the code range still for this year is 99421 to 99423. For non-physician telephone services, 98966 to 98968. You cannot report an E&M for this. Non-physician telephone services. You do not report an E&M. For qualified non-physician healthcare professionals online digital eval, use 98970 to 98972 or your Medicare codes G2061 to G2063 for your Medicare patients. And your place of service would be 11. Now, also I want to note this here is communication methods. No matter if it's via the patient portal or telephone. This would be for qualified non-physician. Okay, so basically, it's kind of established for the most part how you would, talk to your provider. So there's a couple of them. Just take heed to them. And then I just put this here together here, the telehealth, telephone, online digital E&M. And what I've done here is I've targeted to new patient and established patient, okay, along with the time incremented. In this column here, this is the CPT typical time, but this is the CMS typical time. So either way, whichever you have for your telehealth, depending on how long you will go. Now, when I say CPT typical time, if you look in your books, these are the typical times for these visits. For the most part, CMS typical times is kind of like right in here. You want to make sure that you are capturing the minutes so that you can capture the correct E&M for these telehealth visits. And then, of course, for your telephone visits, it's time incremented as well, 99441 to 99443. Okay, so now that we have gone over COVID-19 and telehealth, if you guys are interested, I want to invite you all to my coding conference, June 8th, 2020 to June 11th. Excuse me. And this is going to be a phenomenal conference. We have some amazing speakers. Of course, it is all done virtual in the comfort of your own home. And you can just see the actual presenters, their topics, and the time and dates they are going to present. Also, this is going to be for $100 for 8.0 CEUs. So it is pending AAPC and AHIMA approval. And the register for the conference, you can just go to my website, mti2edu.org. So please, 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 if you want to hear some topics here, and I can tell you this here, understanding how to code neoplasms is one of the ones we really, really, really need because we don't really see that mostly in conferences. Here's the reference page that I was talking about. Basically, you can just kind of reference this stuff here. You can go to them, click on them, copy and paste them in another browser, but this is where I derived all of my information from. And I want to thank you guys for joining me during this presentation. Thank you guys and hope you guys register for the conference. Thank you.